Well, I'm pleased to be joined today by Larry Wellikson, who is the founding Chief Executive Officer of the Society of Hospital Medicine. Larry, thanks for joining us.
Glad to be here.
So, Larry, I know you're retiring this year, and I have to say you picked a fascinating year to retire. Was that planned?
No, I've been doing this for 20 years. That I was turning 70, and I thought that this was a good time to make a handoff. I think if I was smarter, I would have retired last year, but it is an interesting time to do a transition.
I guess as a starting point, there's so many different directions we could go in, but I maybe let's just stay with this year. How has the COVID-19 pandemic and the discussions around systemic racism, how have they affected SHM as an organization and hospital medicine as a field?
Well, I mean, that's a very complicated question, but I would tell you that, there are 60,000 hospitalists, and we are on the front lines of this pandemic. And interestingly enough, I had a conversation with some of the people that founded this specialty thinking, how the heck would this country have even dealt with this back in the old days with when acute care was managed as a sideline for people who were primarily office-based. But the issues that have come up, it's put on steroids things like telehealth and our thinking about social determinants of care, like poverty and access to care and nutrition and living conditions. But it's created additional problems. We're now facing, we're a relatively young specialty. The average age of a hospitalist is 37. But we're starting to see PTSD kind of issues. As you might imagine, hospitalists probably would see in the past 2 deaths a month on their service, and some of them were seeing 6 deaths a day. So that's been sort of the upshot, and I think as an organization, as you might imagine, in a young specialty, that it is not all older white males. And so even with us, we've been dealing with it. But I think it has just sort of lifted a scab, if you will, and forced conversations to the forefront that probably are long overdue. And I think there's always a disconnect in a young specialty between the race and gender of the doctor versus the race and gender of their patients. And once again, this may have uncovered things, and happy to talk about this more in detail. So we're not immune to these problems. It's created new opportunities as well as new problems.
Well, and one of the things that's always impressed me about SHM is because it's a relatively new organization around a new specialty, you don't have a lot of what I'll call legacy systems or programs that older organizations have and older specialties have. But you also don't have kind of the experience, if you will, or the history with these types of seminal events. How is this situation changed your thinking in terms of both the role of the society, but also the role of the specialty?
Well, I think one of the advantages we have, which I talk about frequently, is in the early years we had no reputation to protect, and it allows us. We never think, and we still certainly don't think 20 years later, that we have arrived. We are not establishment, and so we are actually much more like a .com company or a Silicon Valley company where we expect things to change. So we didn't know what it was going to be. We didn't know it was going to be a pandemic and racial unrest, but we always expect that we don't get settled. And so almost immediately on our special interest groups that talk to each other virtually, that people almost on day one of these events were talking about, okay, here's how we need to modify how we approach things. And so I think it actually has made it easier for us to have discussions. Also, we don't usually think we have all of the answers. We're happy if we have some of the answers. And we have seen coming a major reorganization of healthcare. Some people are looking at it as population health, and we're looking at it. Most of our doctors have always been employed, but we're looking at the intrusion of Amazon and Walmart and CVS, and we think that the response to the pandemic of sort of shaking everything up and creating an opportunity to reinvent things plays into both the culture of hospital medicine, the fact that we're not set and we're ready to evolve, and gives us certain opportunities, because we believe that not every specialty that has been successful in the way things were done are going to be in the same position. The disadvantage in the short term is that because we're employed, it was very easy for some employer to just cut our compensation by 10%. So there's some short-term pain, but we think in the long term we're sort of set for the evolution that's clearly coming.
And as part of that evolution, and as you mentioned, employed physicians, I know there's a large sort of private equity play in hospital medicine. How has that affected the specialty, but also the society?
Well, it's sort of interesting, as you know, that people from companies from your world have come over. Frenzius was an owner of a company that employed, I think, over 3,000 hospitalists at one time, and it is both an opportunity and a two-edged sword. I think for physicians, it is always important to have clarity of who decides what a good outcome is. And I've always felt, and I certainly have been on the venture capital side of things, that as a physician, you must start with the basis that if it's good for your patient, it's probably good for the company you work for. That being said, that isn't always the case in how it feels on a day-to-day operations. But like I said, I think our young physicians, by and large, have come into a world where they've always been working for somebody, the hospital or a venture capital-backed or equity company, and so they don't know any different. And it's sort of like if you were born into a place where you were living on a commune rather than in a single-family home. That's just the only life you've ever known. So I think we're prepared to navigate that. What happens is not uncommonly, our doctors who started as a frontline worker move into management. And I think as more of our doctors become CEOs of hospitals or chief medical officers of these companies, they bring with them their experience on the front lines. So I think it is a world that we live in, and we just have to figure out how do we continue moving forward in that world.
So you mentioned nephrology. I'm just curious as to how hospitalists or how the sort of hospital medicine community views nephrology and how you see the two specialties evolving over the next 5 to 10 years.
Yeah, so I think what's happened with nephrology and many other certainly medical subspecialties is that one of the drivers of hospital medicine has been that most specialties have wanted to concentrate on what they're good at and to some extent what makes them the most money. And so cardiologists have been happy to have us admit their chest pains, and they can concentrate on doing the invasive procedures. And I think to some extent, I would be surprised if most inpatient nephrology isn't being done by hospitalists. On the more difficult and complicated cases, certainly involving a nephrologist as a consultation, but very often the hospitalist is a primary care doctor, which allows the nephrologist to be freed up to do dialysis, manage end-stage renal disease, and to do things that they can control, because it's very inefficient for most specialties to come into the hospital for very few patients where the compensation isn't nearly as good. So I think what we've seen is that we need to have an expertise in the management of the acute aspects of renal disease, and then obviously use them like we use most other specialties when we get sort of over our head to call them in. But I would bet you that most hospitalists probably see nephrology as an outpatient specialty, the way we view rheumatology or
or endocrinology. So just kind of picking up on that and trying to link it to where we started when you were saying that it would be hard to imagine the current pandemic without having hospitalists on the front lines. Can you just appreciate if you could just sort of provide the history of hospital medicine and how we kind of got to this point in the specialty?
Right. So when I showed up, bumped into hospital medicine back in the late 90s, there were a couple hundred hospitalists, maybe less than 1,000, and it was being driven at that time a little bit by managed care, wanting to have sort of their own admitting force, if you will. And there's now 60,000 hospitalists, and the driving forces early on were, number one, that certainly family medicine docs and many general internists would be just as happy not to come to the hospital. Like I said, they made more money per hour in their office. That taking care of sick people is more complicated. It was getting hard to keep up with two sets of literature. But very quickly over time, the subspecialty community, certainly the cardiologists and the pulmonary guys, et cetera, found that, boy, they would offload the stuff they didn't want to do, like the admitting out of the ER. And so all that drove hospital medicine. And then you had another factor, which was there was a real move to efficient and effective care, reducing lengths of stay, reducing use of resources, especially in those places where there was managed care or people were taking risk. And so when the hospitals would take on risk for their inpatient care and eventually for their nursing home care, that they wanted a set group of people that they had some relationship with, either as a contract or employment, that became hospitalists, so that they could begin to drive down the use of resources. And then you throw in the mix that insurance companies began to see this as a real advantage for them. So primary care doctors, subspecialists, insurance companies, CMOs of hospitals, all wanting to take away the fact that at a given hospital, 600 different people could admit a pneumonia and bring it down to a smaller managed group. That drove the early years of hospital medicine and the rapid growth, which grew much quicker than say emergency medicine grew, where we went from family medicine guys in the ER to now we would find it unusual hospital where we would not have hospitalists or ED docs.
So in the beginning, the society was called the National Association of Inpatient Physicians, and I'm just curious as to what happened, what sort of precipitated the name change.
Well, a couple things. Number one, I think we wanted to define a new specialty. So hospital medicine, sort of like critical care medicine or emergency medicine, and we felt that we were doing the acute care, and really even now hospital medicine might not be correct with hospitals at home and our major role in nursing homes and LTACs, that we really should be the Society of Acute Care Medicine, but we're hospital medicine for the time being. But in addition, that it became very clear we were not just physicians. So we have a strong membership of nurse practitioners and PAs. We have pharmacists. We really early on saw that inpatient care was a team sport, and that rather than have separate and sometimes competing organizations representing the nurse practitioners in hospital medicine or the pharmacists in hospital medicine, we created a big tent. And this was intentional, and this has required the physicians who tend to want to hold the power, et cetera, to really be inclusive, and it's changed sort of the way that our organization has functioned. So we have non-physicians on virtually every committee. They're on the board. They can be president of the organization. So it really was an attempt to broaden our scope, define a specialty, and also to recognize that we're part of a big tent team.
So as you look back over the last 20 years, what's your biggest regret, or what mistake do you feel has been the one that you never forget about?
Well, sometimes I'm sorry that we didn't early on create our own training programs and specialties. So as you remember, anybody who's listening to this, that emergency care started out being under surgery and internal medicine. And as a new specialty of emergency medicine came about, they developed their own residencies and their own departments of emergency medicine and eventually their own certification. And hospitalists are family medicine docs, internists primarily, and pediatricians, med peds, and each of them have their individual training programs. And in fact, one of my big regrets is that the internal medicine training program for new residents, which become hospitalists, hasn't changed very much since I was a resident 47 years ago. And there are so many things, whether it's population health or risk management or quality improvement, that I am certain that if there was separate hospital medicine departments, a separate board certification for hospital medicine, that we would be better training hospitalists for that career. Now, the good news is one of the main reasons that people set up separate departments and separate boards is to attract medical students into their specialty. And we've had no trouble with that. But early on, our academicians did not want to take on the very powerful internal medicine department to try to carve out their own specialty. And, I wish we had tackled that early on, but that ship has sort of sailed.
So it's interesting you ended by saying you think that ship has sailed, because I could make the argument, and you and I first met when I was working for the quote-unquote powerful departments of internal medicine. And so you could make the argument from, let's just say, nephrology's perspective, but also some of the other specialties you mentioned, like endocrinology, that one way that internal medicine in the future could look more like surgery, where medical students have an opportunity to match directly into fellowships or into hospital medicine, if that's what they're thinking of in terms of their career. But it sounds like you don't think that's a likely future.
Well, yeah, like I said, I think academic medicine is an anachronistic kind of world that is not connected to reality. It'll be interesting to see when Amazon and Walmart are a big factor in healthcare if they don't change it. I think everybody knows that Kaiser became so unhappy with the kind of residents that were being turned out that they created their own residencies, and actually in California have created their own medical school. And it'll take some external force. The academicians on their own aren't going to wake up and do what their consumer, which is the trained nephrologist or the trained hospitalist, says to them. In fact, they don't even survey. I don't know how it is in nephrology, but they've never surveyed any hospitalist to ask them whether their training was adequate for the career they picked. So there's no feedback loop. But I agree. I mean, I think that it seems anachronistic that everybody has to flow through 3 years of internal medicine. And I don't know how you feel about nephrology, but you certainly could train a cardiologist in less than 7 years out of medical school. And one way to do that is to have people match right out of medical school into cardiology, nephrology, or hospital medicine. But I just don't see the tipping point of how that's going to drive, because right now that decision is totally in the control of academicians and to some extent the boards, and there's no driver to force them to change.
Well, and what we're finding, and I anticipate we'll get some criticism for these comments, but what we have found is we've approached both the ABIM and the Accreditation Council for Graduate Medical Education, is there's a little bit of a vicious cycle in the sense that it's not clear where you start. So if you and I came to them and said, we have this great idea, we want to create a program that's going to create, I'll call them nephro-hospitalists, you can call them hospital nephrologists, but the point is, we think there's a need for a patient population. We think there's a lot of interest from employers and from health systems, and we think that it would be best for patient care. If we came forward, it's not clear what the first step would be. And I would anticipate that we started this conversation talking about COVID-19, I think is we're forced to reevaluate our educational systems, including academic medicine, and as there will be changes, I think, in terms of how we handle, undergraduate and graduate medical education. I could see real pressures to try to experiment and pilot some of these new sort of innovative approaches.
Well, I mean, I think at the end of the day, one of the drivers is are people selecting to go into that specialty. Right now, in order to get into some of these subspecialties, it's a barrier, to go through internal medicine, and it increases the debt load. And as you know, that part of this is also the need for medical schools to provide the service they need to the catchment area, very often in poverty areas, underfunded areas for healthcare. So there's many different factors. One of the scenarios you could imagine is, I suspect, when all of these equity firms and commercial enterprises get into healthcare, I think the aggregate of what physicians get paid will go down. And in the end, that will make it harder to justify being in debt and having such a long training cycle. So it's very inefficient. We'll see whether it happens in my lifetime. I've got another 25 years. It may change, but like I said, as you mentioned, it's not even clear where the entry point is to bring a new idea forward to do a pilot program. But, I think the current system is not serving the population or the people that select that career well, and there's a better way to do it.
So, I'd asked you about your biggest disappointment. What are you most proud of?
I am unbelievably humbled by the hundreds, maybe it could be thousands of people who I have interacted with where I have had a positive influence on their careers. One of the things about retiring is it's sort of like going to your own funeral while you're still alive. And one of the things I did for myself is I wrote about 200 or 300 letters to people that I've met along the way. And it made me realize that people keep coming up to me and saying, "You met me when I was a resident at the University of Chicago, and I became a hospitalist, and now I'm on the board of the ABIM," or you talked to me when I was a frontline hospitalist, and now I'm the chief medical officer of my health system. And I think it is an unbelievable. I think those in your audience who are academicians probably appreciate that. But the ability for people to look back on your interactions and to remember something big or small that you did for them or with them, and can look back and say to you, you had a positive influence on my career, my marriage, my relationship with my children, and that is it's just an unbelievable feeling, and the fact that you can recognize the tangibility of that is way better than any money you earned or any plaques you have hanging on your wall, et cetera. And I think it's interesting because it's very similar to the feelings I had when I left clinical practice, was that running in to patients, years later who would tell you, I was sick and went to the hospital and thought I was going to die, and, you treated me, or when my mother died, you came out and talked to me. I think it always comes back, Todd, to your interaction with people is so much more deep and intimate than things you've created, buildings you've built, organizations you've run, power you've had. So it's a good feeling, and you can tell by the way I talk about it, it really is a tangible thing.
Well, Larry, I was one of the recipients of one of those letters, and I happened to get home from vacation, and it was in the mail, and I opened it, and I shared it with Allison, my wife, who and we talked about just how important you've been to me, both professionally as a mentor and just someone that I could bounce ideas off of. And you and I have always, as you said in the letter, have been completely transparent with each other, but we've also been comfortable having discussions that sometimes drifted into areas that would make perhaps others a little uncomfortable. But more importantly, you've been personally someone I've sought out advice both about my career, but also just about how I live my life and the kind of person I want to be. And I know you have your own children. So I appreciate you sort of adopting me as a fourth son. But I think the piece people I want to convey in this interview and in this conversation is, for whatever reason, you and I have spent a lot of time in meetings. And in the first, when we first met in the late 90s, it was rewriting the Constitution of Internal Medicine that ACP, ASIM had sponsored. And now we both sit on the board of the Council of Medical Specialty Societies. And we always managed to sit next to each other. We always managed to entertain each other. But I always come away from those discussions and those meetings with a list of ideas. And, I get home and half the ideas are bizarre and crazy and not workable, but there's always a handful that are just terrific. And I think they've made ASN better. And before that, I think they made the Alliance for Academic Internal Medicine better. But ultimately, you made me better. And I just can't thank you enough. And I know I speak for a lot of people. And again, there's probably some comments in this discussion that will upset some people. But I think if they take a step back and look at the bigger picture, you've been a really positive force for hospital medicine, internal medicine, and the broader sort of medicine in this country. So just thank you for everything.
You're so kind, and I think it's a two-way street. I try to tell my children that very often when you give somebody a gift, if it's the right gift, that you feel better as the giver than the person who receives it. And that's sort of the way our relationship has been. And sometimes it's hard to tell who is giving and who is receiving. And I think if people can get to that, I firmly believe my kids all went into teaching. And I firmly believe that they saw in my life that there's an opportunity for almost everybody has something they can share with somebody else. And I think that's what makes life special and rich. And so I appreciate that. And I know you and you are not going to be defined by what our jobs are. So this is a very nice thing to do on the last day that I'm the CEO of SHM. It's a very nice gift for me.
It's a gift for us as well. So thank you for taking the time, and congratulations on a remarkable career. And I look forward to working with you on CMSS for the next couple of years. And I'm sure we'll continue to come up with half-baked ideas that may ultimately, turn into something real. So thank you for everything.